With technology active. Thanks, Chris. Appreciate it. Buddy, thanks for being here. Apologies to Craig and Dennis, but it looks like Dr. Vogel has once again supplied us with cookies. So, without a doubt, there is benefit from being at home, but there is greater benefit from being here.
I can smell them from here.
Google has gone places we never even dreamt they would. Wow. All right, if we can start, actually, just a quick review of who's here and who's not, and so we can make sure we have a quorum. I see Drs. Doynow and Halpert, Dr. Vogel, I've got Dr. Guthaler, McHugh. Anybody else hiding that I'm not seeing? Myself, Dennis, and Craig, and I believe we have a quorum. Rich? Yes, we have a quorum. Excellent. Dr. Broder is our official pharmacist du jour, and Dr. Zucker is joining us today as one of our residents. Thank you. Initially, we'll just briefly review the minutes from April. Does anybody have anything to add or correct? Minutes from April. Excellent. Motion to approve, please. Dr. Vogel, second. Dr. McHugh, all in favor?
This one is as lethargic as the previous
What?
one. This one's as lethargic as the previous one.
It certainly is lethargic, and I don't know why, because no one should have eaten enough of those cookies yet to be somnolent. So, correspondence briefly. Dr. Mao is excused and now present, I think. Oh, sorry. Wrong.
I'm here.
Dr. Ushkow is excused because we haven't quite gotten to the level to have people participating while they're working, because that just seems wrong. We have a letter from Colony saying that low pressure is in short supply and that they have backed off to 2 units of metoprolol per ALS bag right now. I would expect that would likely be happening at other agencies as well. Any other notifications from agencies? No, nothing else. Mike, anything else that you've heard on?
Not that I've heard of.
Okay,
No.
good. And Community in Boston Spa said that they have stopped providing contracted ALS care for Boston Lake. That actually has been picked up now by
E5.
E5 is doing that now, and we've received a list of their providers here locally.
Doug William. Rich was inquiring as to who E5 is.
It's a staffing company through Southern Warren County, using regionally credentialed medical down here. Exactly, working through the medical director at Boston Lake. System in established. We got notification from the state of an additional award this year, which is going to be for excellence in EMS quality and safety. Criteria itself: the service must have implemented a practice or made significant contribution that enhances the focus on the delivery of EMS in the community. The practice should lead to a measurable and sustained improvement in EMS provider safety, patient care quality and effectiveness, or efficiency of EMS response or resource deployment. And then it goes on to give additional information about programs and methodology. There's going to be 2 honorable mention awards as well as the award itself. This is the first time this award has been granted. We at this point are still collecting until when, Tim?
May 10th.
Until May 10th, we're collecting applications for the EMS awards. So please, if you have some people that you believe are ALS Provider of the Year, BLS Provider of the Year, Communicator of the Year, please get them in, as well as this new EMS Quality and Safety Award. Barry, anything else to add on?
I know I say this every year to you guys, and you guys always come through, but the EMS Memorial is May 21st at 11 a.m. As of 1 o'clock this afternoon when I left the office, I only had 2 ambulances signed up to be there. It's rather embarrassing because this year all the politicians are going to be there because the Senate does not work on Tuesdays. I don't want to say they don't work, but Tuesdays are not in session, I guess is the correct terminology. So, if anyone, we've got quite a few. I mean, it will be a good chance for showing. So, anyone interested, please call our central office and talk to Donna.
Thank you. Thank you. That is the same day as the Albany Med Education Day, which becomes a problem for some folks. One of the things that we are planning on doing that day is we're going to have a film crew go down there and record some of the commentary so they can bring it back and share it with the people who are at the Education Day. So people at the Education Day will get some of the memorial experience, but unfortunately we won't be there to support the honorees. If I remember correctly, 2 names for the wall this year? Aaron?
Correct, Eric Monti from Champlain and David Restuccio from Staten Island.
Okay, so, trying to remember,
Champlain
Eric
is
was
Eric was
he had a sudden cardiac arrest while
sudden
driving
cardiac
an
arrest
ambulance.
while driving to the hospital. He actually, I know Eric because he's from this Mountain Lakes region. His wife had cancer and traveled quite frequently by ambulance to the hospital, and that's how he got involved in EMS. Was looking to becoming an EMT. Sudden cardiac death. His daughter is 14-ish, 14, 15. I know they are sending down an ambulance for the event. And the other fellow was retired from either FIDNY or NYPD.
He was an FDNY, EMT, I believe he was a lieutenant.
He had retired
lieutenant.
and was working for University Hospital and was hit by a drunk, possibly. It was a vehicle accident that claimed his life.
Yeah. All right, thank you very much, and hopefully we'll be able to get a significant showing there for the people as we put them on the wall. One additional piece of correspondence that came in to me by email this morning, and I spoke to him. Dr. Bosco apologizes for not being able to make it here today. He has a visit in the emergency department this afternoon that he needs to attend to. But at the same time, he also sent along a note from St. Pete's that all the medical imaging is going to be shut down at St. Peter's on Sunday night into Sunday morning, May 5th, from 6 a.m. to 8 a.m. This will not involve portable x-rays, ultrasound, or nuclear medicine. However, that will leave us in a position where St. Pete's wouldn't be able to meet their standards for stroke. And do expect if someone's inbound there with a potential stroke that they will be diverted to another stroke center. If it sounds like it's going to be a vascular emergency, significant amount of pain radiating straight through to the back kind of thing, that patient will also be diverted to a center that will be able to study them.
What the times again?
6 a.m. to 8 a.m.
Was your shift done?
On Monday morning?
It's actually Sunday morning at 6
Sunday
a.m.
morning.
Sunday morning,
Yeah,
May
it's Saturday
5th,
to
6
Sunday.
a.m.
So it's
So
only
not-
2 hours.
It's not Don's. Don's off the hook.
18th?
No,
What was
No, the 5th, May 5th, May 5th.
it's basically the Sunday.
This
Well,
Sunday,
it's Saturday night into Sunday morning.
Saturday night into Sunday.
How is 6 a.m. to 8 a.m. Saturday night into Sunday?
I don't get that, yeah.
It's the shift, the shift is the Saturday overnight.
But the hours it's down are on Sunday morning.
Yeah.
Okay.
Now, along with that, Sam says that this will probably only be down for an hour or less. The time allotment that they say is the outside is the 2 hours, so we're not going to actually put a note out to public safety answering points because of the potential for confusion and patients not getting there after it's open again. But if you hear any commentary about ambulances being diverted to another center between those hours, that's why. They're going to be making sure that the triage nurses are hyper aware during that time to send patients to other facilities if it sounds like they're going to need an emergent study. But after that, they should be up and running and all set. All right, Don, committee reports from academic, please.
Not a whole lot to report. The main issue was the PE tape generation that you're doing, so I don't know if you want to mention anything about that.
We can do it under old business.
Basically, that was essentially it. Some courses in Remo, Hudson Valley. Nothing else?
All right, Remsco, anything else? Rich, anything there?
Just that we approve funding for the videotape.
This all seems to have a theme.
It seems to be a
Okay.
theme, right?
SEMSCO and CMAC, probably no meetings until September, October,
told-
what year, we're not sure.
Yes. We were told last week that maybe a fall meeting. A definite maybe.
Okay. All righty, and the Hawk. I see commentary on Shannon McDermott leaving.
Heading up to Saratoga. And it was a quick meeting. The only other thing, and it's a refresher, is the BDLS and ADLS coming up in June.
Right, if anybody's actually hasn't taken those courses before, they're good courses. UT Southwestern puts them on and does a really good job putting those on. Bring the whole show to town. Some agency upgrades in there that just for notification, public access defibrillation notifications in there. To go and do old business first and then some new business. Old business, Pediatape chart design. Docs, I sent around copies of the Pediatape information to everybody. So you'd have that just to be able to make some scribbles on, so we could get some commentary on what other drugs you thought should be on there and what drugs should not. The plan would be to make sure that all of our benzos are reflected on there, as well as the opioids, and what should come off the top. So anything in particular, you can just scribble some notes on there and we can move forward with the project. Any comments as you've reviewed the stuff at home? Rob, anything? Okay, Catherine?
How much
Okay,
does
so
this
the
cost?
council, what?
How much does this cost?
That's a great question. Tim is still researching costs. We have a $5,000 budget from the council. At this point, at least, we've got, we know that the tapes themselves will be $3 a piece, and then it'll be a question of what we can put together for the books with the information in. We'll see what that costs on top of it. Our protocol books ended up at what, $6.50 a pop?
It's a little bit more than that, $7, $8 somewhere in there,
Okay.
7 and change.
But that was 80 pages worth of stuff. Here we're looking at, 12 pages, 12 to 15 pages. So it'll be much less in terms of the number of pages, but it'll also be a much shorter print run, so that may also drive the cost up. So where that's going to tease out, I couldn't tell you.
And this is one per provider or per agency, or how's it going to go?
Actually will be a package tape booklet as a trade for Braslo tape.
Per unit?
Per unit.
Rosalind.
Right, because we keep, currently most agencies store their Braslo tape with their pediatric equipment,
Right.
so this would just be replacing it in that position. Yeah.
And what are you going to do with all the old Bronco?
Tim's going to put them on eBay.
Oh,
Unless, are you looking for some?
no, but I mean, you can make a profit, sell for 20.
Frankly, I thought he might be able to.
So you want to make money on us, that's why you're doing it.
Exactly, exactly. Perfect. Ken?
What are you gonna do with agencies that don't have Braswell tapes currently, that are running some other form of mechanism, PD wheel or something like that? Is there gonna be a cost to them, or is it just gonna be a here you go?
It'll be a here you go. Goal is to get
Everybody
good
on the same
data
page.
out there that everybody will be on the exact same page. And to make sure that every emergency department that's doing any medical control has the exact same data to be able to share with their providers. Because that way, when Amanda's answering the phone at Albany Med, she'll be using the exact same thing to give information that Dr. Vogel will be over at Memorial. Right, and basically, this is saving Mike, how many thousands hours of work putting this exact same thing together?
Exactly, and this, so it's, I mean, just to kind of clarify from my own mind, so these cards that go along with the Pediatape will be specific to our protocol with our protocol doses.
Exactly.
Also, too, you asked me to gather some feedback from some folks, and there was considerable feedback. How does the Safe Dose application on the smartphone play into all of this?
It doesn't, just an alternative, an additional tool,
Okay.
not equivalent, because we can't create the Safe Dose app to fit this
Okay.
on those doses as well.
Mike, are we going to open this up to all the other regions that use the protocol, or is this just kind of a
Tim's
consolidated-
reaching out to them as well.
And for the other services that use something other than Braswell, you're going to still collect theirs, so we know everybody's working off the same thing, so it's not going to pull up for a
That'd be the
meeting wheel
goal.
that's been sitting there for 10 years.
Yeah, that would be the goal. And then the goal would be, as Jeff actually brought up, to make sure that we keep this in line with the protocols, update this with the protocols, and actually put it in the back of the protocol manual as well, so each provider would have that information if they're working from paper. Matt?
Yeah, just forgive me if I didn't get this on it, but I could see clearly the dosing based on weights, but I didn't see a mechanism to estimate weights based on it.
The-
I'm sure
The Pediatape actually that we're going to give out with it is actually Taylor's tape with the same colors set up by Broswell. I guess he sold the idea, but not the specific colors to GE, so the colors remain the same. I don't know how that works out.
So this is pastel tape.
Couldn't see that, obviously you don't see that on the screen. so.
Right, right. All I sent out was the PDFs that we would be adjusting through them in order to create the product that will end up serving us. So. Anything else? Okay, great. With no further ado, let's go into our annual, or slightly less than annual RSI reports. I do have notification from Dr. Funk. She will be making LifeNet's report next month, and she apologizes to everybody. Unable to do this today. We start to our north. You guys want to start?
Give me, who are we starting with?
Nash, Mike, you guys want to start?
So as I alluded to when we began, Wilton, Schuylerville, and Monroe decided to submit collaborative data since we are kind of a system up north. Each individual, if you're interested in the individual agencies' specific data, they're attached to this PowerPoint as well, if you want to advance.
Thank you.
So between the three agencies, there was about 4,700 calls, 30 cardiac arrests, 36 intubations, and 8 RSI cases. There were cardiac arrests that received King Airways. There was one, I believe, that was a BLS airway case as well. So those are the statistics for collaborative statistics for the three agencies. Chris?
Thank you. Give me a second.
So scene times, the mean scene time was 28 minutes. The minimum was 20. The maximum was 48. And then there is one difficult case that Monroe EMS is going to speak about.
I don't know if it was so much a difficult case, it's just, it was a poor patient outcome. It was a chronically ill male, he was a 73-year-old, just released that day from a prolonged hospital admission for exacerbated COPD. It also had a history of CHF and asthma. Called 911 because he got acutely short of breath after walking back from the bathroom. When the providers got there, he was using accessory muscles, end titles were high, sats were low. They tried some conventional means.
Go back
they
to your home screen
not
there.
breather mask, an
You
IV,
should see that I've
soluble
reinvited you
mag
to hang out,
sulfate,
so go ahead.
albuterol atrovent. They ended up assisting his ventilations and nebulizing albuterol and atrovent through the divalve mask as well. The determination was made that they were going to
Where that
collectively
red box is,
chemically
where it
paralyze him
says
and
1
intubate him, and he
or
arrested
2 or
during the
6 or
procedure.
whatever. Go ahead and click on that.
So he obviously subsequently got an airway, and they tried to resuscitate him, and he ended up expiring, unfortunately. Happens to be my friend's father, so that was a crappy case.
Sounds like a profoundly crappy case.
Yeah, it was.
Did you have other stuff? I'm sorry.
Not unless they wanted to review individual agency data.
Okay.
Mike, any specific
Okay.
take-home learning
Thank you.
messages for the other MFI teams you want to bring from that one, or nothing specific that comes to mind? It was just one where everything was going wrong and I kept on doing it.
Yeah, I mean, I reviewed the case. I actually ended up showing up at that particular call at the end of it when they were moving him to the ambulance. And I reviewed the case. I talked to all the providers. And I'm not sure that myself as an individual, I would have done anything differently. I think they tried to be conservative with this gentleman, just knowing his history. And it got to the point where it was, all right, we need to intubate him. And, he was still somewhat conscious. He had a gag reflex. So I guess their choice at that point is to nasally intubate him or, be a little bit more humane and electively chemically paralyze him and attempt to intubate him that way. And unfortunately, I don't think he really had much of a reserve. And with his history, his outcome wasn't as good as we expected it to be.
I think based on the case presentation, it's about what you expected it to be.
Well,
I mean, a patient like
you would
that,
hope it
even in
did.
the ER,
Right.
when you're
You hope it
RSI,
doesn't
you're
turn
like,
out that way, but-
yeah.
I mean, I think they made the right decisions. I don't think
as Adam as you can, do you start by giving him epi before you intubate him? It's an interesting idea. I'm not really sure I want to give live people IV epi if I can absolutely help
They
it.
have it uncapped and handy.
Uncapped and handy is probably not a bad idea. Titrated small doses maybe, or maybe this is even a case if this guy did Brady into it for atropine ahead of time.
We have to look and see if it's been studied. I just kind of, you know it's going to happen. It happens all the time. And yeah, you can wait for the probe and then give epi, but why not give epi before they do it when you know it's going to happen? I mean, I'm not saying we should start doing that. I'm just saying I'm not sure it's been studied.
He actually did get atropine IV during the course of the MF5. He did Brady down at a certain point, and they gave him 0.5 milligrams.
Probably pretty acidotic when you first
Right.
Oh,
started,
sure.
so
Absolutely.
this may have been a case of, but if you're already bagging, you just like try CPAP and things like that. But then you get a heat valve for a couple minutes, but that's even. But Epi, I don't think there's any data on it. I don't think we're ever going to get data on it.
No, I think it'd be awfully tough to collect any data on that.
Have them sign real quick.
That's right.
Because it might save you to do nothing. No.
Yeah.
I'm ready.
Go ahead. So for Colony's program, there were 9,544 calls. There were 60 cardiac arrests that were worked. Of those 60, there were 50% at ROSC. 91 total intubations and 18 MFIs.
I'm sorry, 50%.
Scene time, 32.3 minutes was the mean, maximum was 50, and the minimum was 11. We looked at the two, if you go back, we looked at the two, there were actually two cases that had exactly 50 minutes. That was the total on scene time. That didn't really reflect how long the MFI took. One of them was a skiing accident at one of the local mountains. A bunch of extremity injuries. They had provided pain management, had the patient all packaged up, were rolling towards the aircraft, and the patient wasn't responsive. So they had to stop and do the RSI, so that equated. The other one was a cardiac arrest reversal that they ended up having an RSI. So we did some little breakdown for you. 56% of the RSIs were done in the helicopter, 44% in town. As you can see, the breakdown of medical trauma. Life bearer, obviously, all trauma. 55% of the medication-facilitated intubations were accomplished just with etomidate. So some of the things that Dr. Daly and I are working on with continued training, and we have spring and fall cycles. We just finished our spring cycle where every paramedic had to go through an intubation checklist and an RSI on a megacode mannequin. We'll do the same thing in the fall. Continued scenario-based training. We've also been bringing all of our folks down to the cadaver lab with Dr. Daly and doing additional cricothyrotomy work as well. And then we've been getting some animal trachs to do additional training as well in our spring and fall cycles.
There's only one location that I know of where you can actually get tracheas, and it's got to be a place that actually butchers the animals right there, because the standard butcher shop gets a side of beef or a side of whatever in, and doesn't actually get the rest of the animal. So if anybody knows of a local site where this is done professionally, rather than just someone doing it in his backyard or something, it's kind of scary. But where we can get extra tracheas, that would be good. The learning you can do is fantastic from it. Even if it's just a question of seeing the cords up close and personal and looking at them. This is something that anybody needs some. I can certainly put you in touch with the people, so you can make use of the same resources. These are sheep, goat, and calf tracheas. The calf tracheas are gigundo. Goat tracheas are extraordinarily small and hard to even try to figure out what you're going to do with it. But we've made some pretty good models using foam-backed foam back blankets in order to create skin over the top. We've tried to use chicken skin over the top from a chicken leg or a chicken thigh to create a little bit more realism. That just made a mess, made a big mess. And in terms of the cadaver lab, we've actually changed the way we're preserving cadavers for fresh tissue labs. I was at a meeting where there were some folks talking about doing this. We researched it by doing a methanol and skin conditioner preservation and embalming. You can get a little bit longer preservation time. We've been trying to do live tissue lab, bad term. We've been trying to do fresh tissue labs as often as possible given the availability of the anatomical gifts, but this is enabling us a little bit more lead time. And hopefully we'll be able to get more of the people involved in this. And as we start to put together a schedule, that's something I'm going to let everybody know so we can make plans to get everybody else down. Because it's just too valuable an experience, even if it's just for upper airway training rather than the surgical training. Because the chance just to sit there with a laryngoscope in the mouth and talk about intubation with a paramedic is awesome. So we're going to work to see if we can build that resources as successfully as possible. But Dr. Zucker's actually been pretty supportive in helping us get this off the ground. We're going to keep on working on it from here. So more to come. More to come.
So again, we're planning on trying to get all of our paramedics through the cadaver lab, paramedics through additional simulation training down at the sim lab at Albany Med, and review and discussion of medications. You know, should we paralyze all patients for MFI? Should we use more video laryngoscopes? We've field tested a couple of different. We're still in the midst of doing the glide scope. We've also looked at the King Vision. We still haven't decided exactly what direction we're going to go in with that.
You guys have a glide scope, right?
Yes.
Okay. Mike, do you have one?
No, we don't.
No. Okay. And the one thing that we certainly saw with taking the paramedics and the King Vision up to the cadaver lab is you really have to have enough experience with that thing to really know how to troubleshoot it as you go. And it's a whole different way of working. And the most frustrating thing of all is you can see where you want to go, you just can't get the damn thing there. It's hard. That's really hard.
Glide scope.
What?
It was the same with glide scopes. You
Yeah.
can see it, you gotta know how to get to it.
Yeah, you're absolutely right, Rob. Absolutely right. Now, the interesting question on that, the paralysis for MFI, and this came up with the docs down in the Hudson Valley as they started reviewing our protocols, is our protocols say, try when you've got the etomidate on board. In the Hudson Valley, they're very clear, push the etomidate, push the paralytic, and then try to intubate. There are advantages to both. And it's frankly something I think we should all consider in terms of our practice in the emergency department and what we should promulgate in the field in order to think about whether or not we should make some changes going into 14. But at this point, at least, I don't have any firm recommendations from where we are. It's just interesting. About half of our MFIs in Colony didn't require any paralytics.
Well, one thing is looking at back in December or so around there, came out with the airway complication rate at like the third attempt, you're about 40% cardiac arrest, desaturation, or some bad outcomes. Do we want to take that one attempt just to look and then go to the second attempt? We're already at about 20% complication rate. We're sure we should just do the paralytics first and have a better chance of that first pass.
It's a great question, and actually how we should collect our data. We've been using a standard airway form, and that's something, Rob, maybe if you can take the QI committee would be a good idea moving for the rest of the year, is let's see if that form actually should be changed a little bit to see what else, what other data we can collect that may be a little bit more valuable as we look to change protocol. See whether or not it's something we should be doing.
Mike, do we have enough numbers yet to put out some sort of submission as part of the paper to sort of contradict the bad airway outcomes that have been out there for a while? We seem to do much better than obviously what was from Pittsburgh.
The problem, what we don't have, Don, is we don't have the outcomes associated with the interventions. And I think that was the power of Wang's last paper, was that he looked at intervention and outcome and follow that through, where it's not something that we have. And that would be a huge investment of staff time, I think, so retrospectively, I think we can track that down.
Should we start prospectively? Should we add to the UI form, like the, put down and get the records, and then kind of get the CARES, sort of like the CARES data almost. RSI cases. I mean, it's gonna be 5 years, before we have numbers, but.
Sounds like a volunteer project.
Peter, the 55% that we were successful in accommodating, any correlation between trauma, medical patients, or was it a mix?
It was a mix.
Okay.
Just one
So we can pick up on the meeting.
Are we at ours?
We're getting there.
What do you want to know?
So you said there was a family case.
No, there was.
Who are we going to?
There was a post intubation that you can without it.
Doc?
So basically, Albany County next.
Thank you.
If Albany County's ready. Is Albany County ready?
Well,
Albany County's almost ready.
Albany County's medical director is ready.
The two of you are almost ready.
We were about as ready as we're gonna be since we assumed Brian was gonna do this, but sure, go ahead.
Give me a quick second.
I think he pretty much typed these into the slide, so.
Okay, well, I can see a slide from back
Oh, is that bad?
there. Without the appropriate glasses, these are.
Oh, those are
close
reading
glasses.
glasses. So you so you get, there's these new things called bifocals. You have both, you can get distance and up close. I think you need to make a phone call. Yeah. Say, why you-
Okay, so 2012 data, which I presented the best I can here. Total number of calls, number of arrests, number of intubations. There were really only a very handful of MFIs for the year, 3 of them. Let's go on to the next one.
You had agency comments, and then you had 3 trouble cases, or 3 cases that if you'd like to discuss, just so you know what my slides are.
Yeah, I mean, basically, there's really not much to say here. And then we had some problems there. What you guys could say. Thanks. Thanks, Frank. So some cases.
From under the bus, that should say.
Yeah, yes, from under the bus.
Unprepared.
All right, let's go to the first one.
You have them.
Oh,
you
you
didn't type
didn't
them
put
out.
them in
Verbally.
there?
I didn't type them into here. No.
All right, so one was a 58-year-old unconscious found by his wife, according to the CBA. He was given etomidate, succinylcholine, the circulating dose of rock. Did fine, and no long-term paralytic. 26-year-old male, high-speed motorcycle accident, under lidocaine, did circulating dose of rock. Etomidate, airways secured without sucks, and was given fentanyl for sedation because of hypotension. And then on the way into the hospital, was given 80 of rock for a paralytic, no problem there. 20-year-old ATV versus pickup crash under lidocaine, did a 6 dose of VEC. Etomidate, 120 of sucks, airway secured, was given fentanyl and Versed post-intubation. And that's basically it. That was essentially it for us, not really a whole lot.
I got a phone call last night, asked if I would present this, and I thought he meant just hand it to Mike. So he emailed me this, which I printed out and tried to hand to Mike. But, so, yeah. So that's why the stories are not all that exciting, so, but, wish we could give you more.
If we can go to Gilliland next.
Okay, you got straight on it?
We'll give it a shot.
Thank you.
For those who aren't familiar with the Gilliland system, it's a 2-tiered system. So we're the paramedic service that provides the advanced life support to the entire town of Gilliland, which includes part of the SUNY campus, part of the New York State Thruway, as well as the entire town of Knox. There's 2 basic life support units, primarily that handle the transportation and DLS services. That's the Western Turnpike Rescue Squad and the Altamont Rescue Squad. We have a slight discrepancy in our total calls between the dispatch and our EMS charge. We want EMS charge. We had 4,632 calls, 42 cardiac arrests. 25 of those were secured on scene. There was no attempt at resuscitation. 17 were worked. We had 7 with the return of spontaneous circulation to hospital. As an agency, we're 18 for 23, and the other 5 were secured with the King Airway. So there was basically no airway that was left unmanaged or couldn't be managed, should I say. Then we had 8 MFIs. 7 were intubated with an endotracheal tube, and 1 was successfully managed with the King Airway. And the mean scene time was 26 minutes. The minimum was a 10-minute response time. Reviewing that chart, actually, they were off the scene within 10 minutes. En route, they made the decision to RSI and pulled over and RSI'd on the side of the road. So that isn't really completely accurate, 10 minutes. I don't know how long they were on scene. The chart doesn't really get specific with how long they were pulled off on the side of the road, but it wasn't long. The maximum was a 39-minute, and that was the patient who was upstairs that had to get extricated. No real issues with extended unnecessary scene time there. We did have 2, only 1 problem case. This go over that morbidly obese one. That was just a patient that wasn't secured with an endotracheal tube, but was successfully secured with a King Airway, and that was just information was given to me by Corey. I don't even know, was that an issue doctor going on with that morbidly obese one? No. But this cardiac arrest, this was a patient who walked around the mall and apparently went into seizure activity. Also had, looked like, according to the medic, he was intoxicated. He got on scene, he was a bit post-ictal, he was incontinent, and they were unsure of his medical history, past medical history, etc. He was really combative and complained of difficulty breathing. The medic, the 2 medics on scene felt that he couldn't protect his airway, so they made the decision to RSI the patient. He was on a monitor, and they thought he might have been having a stroke, and they pushed the lidocaine as a neuroprotective agent, and he went to cardiac arrest. And they worked the cardiac arrest. They got him back, and he was discharged from the hospital a couple days later. This was a case that was brought to the Remac a couple weeks ago regarding the lidocaine, when to give it as a neuroprotective agent with rising intracranial pressure. Evidence of rising intracranial pressure, or so just as a neuroprotective agency for our agent for CVA's period. And the Remac decided to make it just the evidence of rising intracranial pressure. So, patient survived, but there was a lesson learned there. Another slide there. Some of the other agencies went into training. We do semi-annual training, which requires the medics to go through mega codes, review of medications, as well as written tests. Of the MFIs, I quickly reviewed. We had, there was 7 of them were medical, 1 was trauma. Out of the 8 MFIs, only 3 of them required us to paralyze with Vecuronium. So 5 of them went down with just atomic. Anything else, Dr. Doyle?
No, the case that Jay mentioned was one that, in retrospect, appeared that he was an intervention for escape from him. And that's probably why I was that I developed. And in the heat of the battle, I could see how they weren't really looking so much at the EKG and script to see what exactly they're doing if they're worrying about the airway. But that's what brought up the fact that really the lidocaine, there's no great data showing what it does a whole lot. And certainly, if we're going to use it, it really needs to be used if there is evidence of increasing the pressure, not for question of if somebody's having a stroke. And even if it was a struggle to bleed, it's certainly not going to do anything. Sure.
I just dropped Dr. Stanger a quick note asking if he was going to report out grain, but I haven't heard back yet.
He is, and I haven't.
Excellent.
And I've just noted him here, so.
Can you guys hear me okay?
Yes, I can hear you fine.
Okay, is that, am I talking too loud or loud enough?
That's loud enough, not a problem. Fantastic.
Excellent, all right, let me, I'm going to bring up my PowerPoint here on the desktop so I can refer to it. So we included 2011 and 2012 data, just because it had been a while since we had one of these reviews. For whatever reason, we had a little decline in our MFIs for 2011. We had 3,500 total calls and 71 arrests, 49 intubations, but only 4 MFIs. And then in 2012, we were kind of back up to typical numbers, about 48 arrests, 29 intubations, and 9 of those were MFI. So we've had about 13 total cases over the last 2 years. If you go to the scene time slide, mean time is about 16 to 17 minutes. Minimum was 7 for both years, 2011 and 2012. And then we had maximums 22 minutes in 2011 and 2012. There were 2 cases, 31 and 45 minutes. Looking at cases at a little more detail, they were kind of out of the hands of the medic. Green Correctional Facility, tough facility to try and get in and out of in a timely fashion. And Hunter Mountain was a